Welcome to the Coordination of Care Success Stories Webinar 4. My name is Erin and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Janelle Shear. Ms. Shear, you may begin.
Thank you. Hello, everybody. This is Janelle with Stratus Health. We are one of the organizations that is part of the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. We are all working with organizations in our states in a community-based approach to reduce the 30-day hospital readmission rate by bringing organizations together in communities to improve care transitions as people move across the continuum of care. This webinar series, Success Stories, highlights the innovation work of the Lake Superior QUIN Coordination of Care Initiative partners across care settings and in the community have done to improve transitions of care and reduce readmissions. This is webinar 4 of the series of 6. So I would like to welcome you to this educational session entitled Home-Based Innovative Strategies to Prevent Readmissions. Because Metastar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speakers and planners have no conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. We encourage everyone to complete the evaluation and to provide feedback on the session. The evaluation link will be available at the conclusion of the webinar. It will pop up at the end, and it will also be in the chat box. And you will also receive an email with the evaluation link after the webinar is over. Participants in a group setting should submit a list of who participated with email addresses to the email on the screen, continuing-ed@metastar.com. The objectives for today's session are to describe an innovative community collaboration that addresses the needs of people at risk for hospital readmissions, to discuss the values of collaboration across settings to prevent readmissions and promote person-centered care, and to identify successes and barriers to implementing cross-setting innovations to reduce readmissions and promote person-centered care. To get to know who's on the webinar today, we have a couple of polling questions. And so the first one is, what type of organization do you work at? And Jenna, you can open the poll. So please complete this, and you'll have about 30 seconds to complete. And if you're an other, we'll have you just put that organization type in the chat. Few more seconds. And then, Jen, I'll just have you kind of let us know who we have on the call today.
Looks like majority is hospital. We have a few home care agencies, a few others, a couple of clinics, but mostly hospitals.
Okay, great. Thank you. And then our next question is, we're curious, what is your profession? We added a few, maybe not so common ones, care coordinator, community health worker, and we're also wondering if we have any community EMTs or community paramedics along with more of the traditional healthcare professionals. And same with other. This time, if you are not on the list, we would like to know what you are. Okay. And what do we have, Jenna?
A couple administrators, a couple of care coordinators, majority of nurses, a couple of social workers, and a few others.
Okay, and let's just go to the chat quick and just kind of see what we have there. You want to just say a few of those?
A couple of nurse practitioners, social workers, home care agency owner, physical therapist, and looks like a couple people who are from the ACO, healthcare system, insurance company.
All right, great. Well, thank you, everybody, for participating that way. It just kind of helps us to know who's on the call. Before I introduce our speakers, I just want to remind you all lines are muted. However, after the presentation, we will have a time for questions and answers, so please make note of any questions that may come up as you listen, or you may use the chat feature, which is on the right side of your screen, and we'll keep tabs on those. We have two presentations today. The first is an innovative intervention in providing hospital care at home for a specific patient population. And the second is a pioneering strategy used by firefighters and CEMTs in being a part of the care team. Now, I would like to introduce our first presentation speaker, Rory Malloy. Rory is a Senior Quality Improvement Consultant with Regents Hospital and HealthPartners. He holds a Master's in Public Health from the University of Minnesota with an Advanced Certificate of Management Studies in Health Services Administration. Rory also has training and certification in Human-Centered Design, Team Steps, Lean Thinking, and a Six Sigma Green Belt. Over the past several years, Rory has led several successful efforts across HealthPartners Enterprise, including the design and implementation of the new care model called Hospital Plus Home, which we'll hear about today, and I'm very excited for this presentation. Rory has also led process improvement work for hospital-wide medication reconciliation, which was cited as a Joint Commission best practice and leads Region's readmission reduction program. Thanks so much, Rory, and I'll turn it over to you now.
Well, thank you. First off, I just want to start by thanking Lake Superior Quality Innovation Network for allowing me this opportunity. And then I want to tell you a little bit about HealthPartners and Regents Hospital and Methodist Hospital where we did this work. For those on the line not familiar, HealthPartners is an integrated health system with primary clinic and hospital locations located in Minnesota and Wisconsin. We have 26,000 employees and 1.8 million insured members across six different states. We have 8 total hospitals in our system. We also have dental providers and 55 primary care clinics, urgent cares, and emergency departments. We have 55 medical and surgical specialties and over 1,800 employed physicians and dentists. We also have our Virtual program that offers 24/7 online clinic services to people in 13 different states. Regents Hospital is a level 1 trauma center. It has a burn center, a baby-friendly birth center, and over 100 licensed mental health beds, with a total of 454 licensed acute inpatient beds. We have over 27,000 admissions a year, and oftentimes, and I want to, this is an important point for some of the purpose we did this work. Oftentimes, Regents runs at capacity with close to a 90% occupancy rate. It is one of HealthGrade's America's top 50 best hospitals for the last 3 years. Methodist Hospital is 398 beds, offers multi-specialty services, and has over 22,000 discharges per year. It was also cited as one of HealthGrade's America's best top 100 hospitals as well. So that just kind of, I think, sets the stage for the organization and what we are and why we undertook this information. And I think when we move to the first slide, it looks like I don't have control. So
Hi, Rory. You'll have to click into the slide, and then on the left-hand side, there's the navigation.
Okay.
Or you can do page up or page down on your, there we go.
There we go. There we go. All right. So in this first slide, we really wanted to show that our program is really about the community, that it's not about the bricks and mortar of a hospital, but rather a neighborhood or a community where we're going to see our patients. And so that's kind of to set the tone and to focus on what we focused on throughout the pilot. We also had some guiding principles that help to drive our work. We want things at HealthPartners to be consistent with the triple aim. We wanted this new care model to be safe, and also to look at how we could reduce costs and minimize patients' exposure to hospital-acquired conditions, and ultimately reduce readmissions. We, across the country right now, are seeing there's a lot of adaptation of new technologies that help facilitate remote access to to patients. It allows clinicians the ability to connect with those patients remotely, and also health systems and plans across the country are reviewing their care delivery models to create new and innovative methods. And so that's where that really kind of set the stage for what we wanted to accomplish when we set out 4 years ago to really try to understand and invent this new care model. We based it off of a hospital-at-home care delivery model that has been tested and proven across the country in multiple different organizations, but we needed to adapt that and to make it work for our health partners, particularly regions and Methodist patients. We also wanted to do that in partnership with a community vendor that enabled at-home monitoring. So with that, the team was tasked with co-creating an improved care model utilizing assets from our organization and as well as that vendor. The primary objectives, as I stated, were an innovative new care model we focused on at the start early discharge of patients, and now we're transitioning into admission avoidance altogether. We provided the remaining hospital care in the patient's home. We wanted this to be a cost-effective alternative and to support the technology, but it also to be safe and high quality. We expected that there would be readmission reduction, minimize future hospitalizations and emergency room use, and then closely align with the patient's healthcare home and promote outpatient visits and monitoring to keep the patient out of the hospital. And we also, I think, earlier I pointed out the point around Regions Hospital. This, at both Regions and Methodist, was also looked at if we could potentially earlier discharge a patient and take care of them in the home. We then freed up access and availability to those beds for more acutely ill patients. And this slide just kind of goes on into some of the things that I've already mentioned. So where did we start? We needed to set some parameters around the work that we were doing, and to set the tone here. This pertains to patients with congestive heart failure. When we looked at our data and analyzed our data, the primary diagnosis that was seen at both Regions and Methodist was congestive heart failure treatment. We often found too with congestive heart failure, patients were staying an additional 2 to 3 days in the hospital just to have their IV diuretics and basic monitoring, and we felt we could do that. We could do that work at home. So we set up some conditional and permanent exclusions for the program. The conditional exclusions really are, what did we look at on a daily basis when the patient was in the hospital? If their respiratory status was worsening, or they had new EKG findings or something like that, they didn't qualify. And at that point, we would continue to review that daily. but then we also had our permanent exclusions. And we set a 25-mile radius away from both Regions and Methodist Hospital in the Twin Cities area. But we found that as we got engaged in the pilot, we were able to extend that a little bit further beyond the 25-mile radius. I think, you know, this list served its purpose, and it was constantly something that we reviewed on a daily basis. And we found that we tried to make our care about the patient, and if we felt we could safely take care of a patient at home, we were able to discharge them. So we started with this list. We had some criteria set up in Epic that filtered these patients out, created a patient list that our case management teams at both hospitals reviewed on a daily basis. They would do an in-depth chart analysis, look at the patient, and then go to the patient and provider and talk to them about if this was the right option for the patient, and ultimately leaving it up to the patient if they wanted to return home early and have the remainder of their care in their home. So the care process, what did it look like? We had that identification, those inclusion-exclusion criteria, the review of the case manager in the hospital, and then we sent them into the hospital at home phase. And that typically lasted up to 4 to 7 days, and that was where we had a physician going into the home on a daily basis, if needed, or connecting via video visit capability. We had community paramedics on the region side and home care RNs going into the home on the Methodist side. And they would do daily cares. They would do daily lab draws if necessary with the patient. And then we also had a device in the home that the patient used multiple times throughout the day where they would record their weight and vital sign information. That information got uploaded to a secure link where our providers could have access to that information and know right where the patient was sitting. We then transitioned the patient into an education phase, and that lasted up to 42 days in our pilot. And that really was, we looked at it early on when we first started creating this model. A couple key team members made reference to, we need to make this be an education drip. So if you think of in the hospital, we give medications over time. Why don't we give that education over time? That oftentimes in the hospital, we try to cram as much information into the patient and their family as we can because we need to get them out the door and back home or to a transitional care unit. But instead, if we looked at taking care of them in that acute environment in the hospital and then at their home, and then as they were more stable, they no longer had an IV, were no longer receiving IV medication, that's when we really started with education around, we had the availability of nutrition, dietary consultation happening. We provided some food in the first 5 days as well, heart-healthy meals for the patient. But then slowly we educated the patient and backed away from the day-to-day care. The physician at this point was no longer going into the home. It was largely the community paramedic or the home care RN. They were going maybe once a week. They were doing phone visits if necessary with the patient, and just continually touching base with the patients and transitioning back to their healthcare home and into the wellness phase. And the wellness phase is really where we return them back to their primary care provider. We helped facilitate, coordinate appointments, all of that done in the patient's home. And I think one of the big wins that we found, and I show later on in the slide, is really that home interaction. That home interaction by our staff was really the most vital component and what we really learned from in this pilot. So I talked a little bit earlier about congestive heart failure, why it was a condition that we selected. And again, just to reemphasize, we were finding in some of these patients the last 2 days of that hospitalization only focused on monitoring their vitals, and we felt that we could do at least test our care model and do this work in the patient's home. We also have a growing population of patients with heart failure, and typically they sometimes have longer lengths of stay. This is a grid that really kind of shows the phases and the technology, the people going into the home with that care model. And so on the left-hand side, you have the acute hospitalization, where we identified the patient, typically tried to identify them within the first 24 hours of their length of stay, and then began to prep them and transition them to early discharge and care in the home. And then in the home, we had a technology device that was used 3 times a day, 7 days a week. And as you can see then, as we move into the education and wellness phase, it was only done once a day, and then we had a IVR or a phone-in option as well for the patients to call in and update their vital sign information. It also has the technology or peripheral views, blood pressure, cuff, pulse ox, scale. We had all of those things in place, and then we also had congestive heart failure trained nurses through the vendor, and our home health nurses. They could answer any questions that would arise. We had it was 24/7 in how we were able to connect with the patient. We had to create some different channels to do that, but ultimately we were able to be available to the patients. And a lot of times it was our community paramedics or those home care nurses that were connecting with the patient, scheduling a time to come out and look at the patient and address any of their care needs. So in the pilot, we were able to, again, as I mentioned, have the community paramedic and physician in the home. Pharmacy also did and completed an in-home medication assessment. A pharmacist came out to the home or did a video call with our MTM program. We provided those heart-healthy meals. We did dietary nutrition consultations, and then that technology monitoring for that 90 days. So I want to get into some of the results from our pilot. We had an 83% experience rating, so that's a top box score. So if you're familiar with the HCAHPS questions for hospitals, it's very similar to that question of how would you rate your overall care, and would you rate it in that top box? With 10 being the best. And so 83% of the patients surveyed rated us in that top box 10. 100% of the patients surveyed said they would recommend the program. But I think more importantly, the biggest experience lesson that we learned was through our positive staff and provider engagement, and then also the positive comments from the patients. Our staff really felt that care was being delivered in the right location, and we were able to, because this was a small pilot and we were in the patient's home, we were able to tailor and meet the needs of the patient on an individual basis. From a perspective of during the pilot when we were actively working at this, at Regions we qualified, we had 23 patients that qualified in the several months that we did this. We were able to enroll 10 of them. And at Methodist, we had 24 patients that qualified and were able to enroll 4. We paused enrollment at the end of the year so that we could retool, and we've been working on retooling what this program looks like. And I have some slides later on that tell you a little bit more about that. But we also found that with the work that we were doing, we had a 90% compliance with daily health checks. We had 0 incidents of patient falls or delirium. Our readmission rate was 15% for those patients. We had 1 readmission at Methodist and 1 readmission at Regions. But ultimately, patients spent over 100 more nights in their own beds. From an affordability perspective, there was 36 saved bed days, and that's important to us, as I mentioned earlier, as we tried to look at this through the lens of how can we reduce length of stay and have more acutely ill patients in the hospital. We were able to impact length of stay on those patients by 2.6 days. We also were able to have 27 additional patient touches per patient outside of the acute hospitalization. So if you think of a typical patient with congestive heart failure that goes home, by us being a part of this, by having them be a part of this program, we had 27 additional connections with them in that 90-day framework to help them learn about their condition, to help keep them out of the hospital. We also learned from an affordability perspective that community paramedic use was more cost effective and a better alternative for us to pilot as we went forward. And overall, our model at Regions was more cost effective, and a lot of that was learned based on provider variability and some different things that we felt as we move forward with this, we will try to streamline a little bit more. And here's just some of the detailed information that I covered around the enrollment already. Here's some more of the quality and length of stay information. As I said, Regions had one patient, which is a 10% overall rate. Our typical readmission rate at Regions is about 18 to 19% for our congestive heart failure population. Our inpatient length of stay on average for Regions was 3.9 days, and Methodist it was 2.5 days. And then the expected length of stay, typically a patient with congestive heart failure stays 6.9 days at Regions and 3.75 at Methodist. So that's where we get our impact based on how much quicker we were able to get patients into their home environment. And then from that, we're able to calculate our saved bed days, both at Regions and Methodist. And the typical in-home length of stay where we had providers going out into the home at Regions, it was 7.3 days, Methodist 10 days. And again, that's where some of that variability comes in. We were able to leverage video visit and phone visits a little bit more at Regions versus at Methodist. There were some differences in how we did lab draws and different things that we found as we roll forward in this pilot. We need to be able to have courier services available and different things to get things into the home faster without having to rely on our staff to be able to do that. Just some additional visit information. We had a total of 13 visits per patient at Regions. That was the average. Methodist, you can see it was much higher. And then phone visits and video visits as well were utilized, and then the overall patient touches. So one of the things I think the greatest lesson I think that we learned and at HealthPartners, one of the things that we really strive for is how do we do this head and heart together? How do we do the clinical, the science piece, but also connect with the patients and understand that connection and what they need? And I want to tell you a story about one of our patients who responded very well to the in-home treatment. We're going to call this patient Dave. And Dave operated a small business out of his home with family and loved ones. He wanted to get home. He did not want to be in the hospital. He had that home business to run. He felt compelled to do that, but he had his family and his dogs at his home. And for him, that made a huge difference that he was able to get home early, that he's able to only have to be in the hospital for 2 days, and that remainder of the care happened in his home where people were coming in to visit him. We were also able to observe Dave in his home environment, and we found that Dave was drinking a 12-pack of Mountain Dew a day. and he had a high sodium diet with a lot of sodium foods in his cupboards, and we would not have been able to connect with the patient in that regard had we not been in their home. And so we were able to teach him, and he was able to learn about some proper nutrition. He ate the 5 days of food that were supplied to him through our partnership with Open Arms. And he also began to learn to cook heart healthy meals at home and followed the nutritional guidelines that were reviewed with him by our nutrition staff. Dave is a great example of and just a really a heartwarming story of, here is this man who, when you actually observe him in his home environment, his dogs were running around. He's seated with his patio door behind him and really just at home. And we were able to give that care to him and return him back to health in his home. We also had other successful patient stories where patients reported just feeling that this program was going to change everything. One said that people are getting older and it's a great way to keep them at home and not in the hospital. We'd be happy to help in any way, and we want to ensure that more patients can receive care like this that we were able to see. There was a lot of great feedback from all the patients that our caregivers were excellent, that the doctors took care of them, and they're still learning. Every day they're learning about their condition. And had they not been able to be in their home, they felt that they couldn't have done that. Had another patient that was able to, over the holiday season, was able to connect with his family and be at home over the holidays because of that. And had a supportive family network, and his grandson and wife could help and continue to help him provide that care in the home. So from a lessons learned perspective, as I mentioned earlier, we learned that there's clinic variation, that MDs vary how they treat and the duration and what they're looking for in different lab draws, how they administer different medications. The IV diuretic actually even used vary. So we found that there was some variation and some commonalities though that we could create, but also to just learning too in the identification process how and when we identified these patients and what preparation they had before we returned them home. Again, as I mentioned, we changed many of the screening and inclusion-exclusion criteria. We found that we needed to be very flexible on the types of patients that we enrolled. We had found that renal failure was acceptable, but we couldn't do dialysis at home. We also set out early that we needed to have a full cognitive assessment. But we learned that the cognitive assessment doesn't necessarily exclude a patient, that especially if you have a stable family and caregivers and they're able to help the patient complete the in-home visits, we could look to do that. And really too, just patient perception. Was the patient willing to do this? I think this was typically patients feel the hospital maybe is the best place for them, but we all know that sometimes that exposes the patient to unnecessary conditions or hospital-acquired conditions that they don't need to be exposed to. As I said, there's variation in the medications, just how we got those medications to the home, how many days supply we needed to have in the home, and things around the medication. And we also learned it was very, very helpful to have the MTM pharmacy visit come into the home and look at the patient setup, how they're setting up their medications, and how they were using them. We also had a lot of learning lessons around the documentation piece. Oftentimes EPIC is hard to get information out of, and so when we first started out to pilot this, we did not create specific EPIC places. We needed to use and leverage different community paramedic notes or home-based medicine type notes that we had already created. And so we learned that there's some efficiencies that we could create there, and oftentimes in order to document the success of the program, we had some of our staff had to be documenting in two places so that we could just understand the data. And so as we move forward, that's something that we need to address. I also mentioned too just the need for some courier services and how we get labs back and forth to the hospital. And we learned a lot about food nutrition, and really was the patient willing to try new food? We found that some patients, some of the more heart healthier meals that were provided to them, the food was outside of the normal palate that these patients had developed, and so there's a level of education and understanding that needs to happen, but also exploring what are some more common meals that we could provide. And in fact, I think one of the patients, a quick story with that, one of the patients that we had never had eaten fish, and fish, some of the fish choices that are provided in the meals, great food, but was very different than what the patient was used to. So we also had some great learnings in partnership and what that all meant, and the technology. We wanted to test, what that technology was like, if technology was necessary. We found that our partner had some great design expertise and innovation center to help support some of our work. The congestive heart failure nurses to answer calls and responsiveness to the patient's needs. But we also really learned that in-home monitoring equipment isn't critical to performing or doing this program. That we can do it without a sophisticated piece of technology, that a normal scale and a phone call will work. We also, I think really this is where we saw the value in, the value really was that nurse or the community paramedic or the physician being in the home, or the nutritionist being able to see what's in the patient's cupboards, or the MTM pharmacist to be able to see how the patient sets up their medications, what they're doing, what their even understanding of the medication that they're taking is and why they're taking it, and the effects, especially with a congestive heart failure patient, a diuretic, understanding that diuretic and what that does. We also saw, we think there's some value, and this is what we use to kind of create our next phase of this. We also saw some value, particular to our HealthPartners patients, that in 2019, HealthPartners has taken on 25,000 new Medicare Advantage members, and we have large employers as well, and we think this could be a model that could support further further development from particularly from our HealthPartners patients and population. So our future model, what does that look like? What do we need to do? We felt that we needed to better leverage our community senior care home-based medicine program and providers, that we could earlier detect a patient. We wouldn't need to have them go to the emergency room or go to the hospital and have that 1 to 2 day length of stay, that we could find a patient when one of our community senior care providers are out in the home, the patient's condition is worsening. Instead of sending them to the ED, could we deploy this mobile care team? And that's really where we're looking at now is mobile urgent care, mobile care that comes into the home and prevents the transport and the ED and the admission altogether. Can we get further up the stream? We also need to create some epic efficiencies to speed identification and tracking. We will utilize community paramedics going forward. We could also leverage some existing video visit technology that we have internally, and we need some additional support in order to grow this program from a pilot of 14. And we've been able to see some patients already in the home through that community senior care home-based medicine provider detected it. we were able to deploy the care team early and avoided a admission altogether. But again, there was lessons learned in that. So we're constantly looking at this in a constant cycle of improvement. How can we continually improve this model and work to get further upstream and prevent admission and altogether. This is a spectrum of home-based hospital care that was created early on, and if our physician leader is on the phone, I don't know if she's going to join today or not. This is not her favorite slide, but I'm going to try to explain it in what I was saying. And where we really started out in our journey was at that post-acute at home. Our goals were to reduce length of stay, promote early discharge, and prevent readmission. Where we feel we need to get to is that continuum of care, where we're finding the patient in the home or when they go into their clinic, or even through the medical plan. So HealthPartners Disease and Case Management checks up on a patient and they feel like the patient's condition is deteriorating. How can we get our mobile urgent care out to the patient earlier and prevent that transition happening even to the hospital? So as we advance our program, the criteria that we've looked at is we're changing the admission setting from the hospital to ED, urgent care, primary care, our home-based medicine. We've continued with some identification and early discharge from regions. We're able to do that we have a very robust community paramedic program, and they're able to enroll and see patients in the home, not in an acute fashion as we did in our pilot, but rather to assess the patient and continue the education at home. We're also looking at additional diagnoses and how we can leverage our community senior care patients as well. And we're looking continually to improve the funding source. How can we fund a program like this when right now across the country there isn't funding for taking care of a patient. There isn't as robust a funding as there should be. So we're also partnering with organizations across the country and how we can look to change and reform payment. And I think I want to wrap up because I know I'm probably pushing the time limit already. But I just want to thank everybody and give you my contact information if you'd like to learn more. This has been really a four and a half year journey for us. It started with this concept and idea, and to actually be able to take care of patients and have the success stories and have the story of Dave that we had in his home. That has made the journey all worth it. So thank you.
Oh, thanks so much, Rory. We really enjoyed hearing the story, and we can hear the excitement in your voice and know that this has been a journey. And so thanks so much for sharing the pilot. If you have questions, you can just jot them down, and we'll open up later or put them in chat. And then now I want to just introduce our next presentation. So if you would advance or pass the ball to, the other speakers. The presentation is called Community Emergency Medical Technician Services Home Visit Program. It's presented by Fire Chief Steve Coring and Amy Lucht. And I'll just give a short intro to both of our presenters. So Chief Coring is a 30-year veteran of the fire service and currently holds the position of Fire Chief for the City of St. Louis Park in Minnesota. And this department has been really involved with the community, looking at overall community health management programs. Amy Lucht is the Executive Director of Care Resources Connection. She's been in healthcare for over 25 years, and she's the founder of this organization, which is a non-for-profit made up of a network of healthcare, public service, and business professionals. Amy has been working with the St. Louis Fire Department and the program that you'll hear about today. So I'll turn it over to you, Stephen and Amy.
All right, thanks, Janelle, and thank you, everybody, for your patience. We'll try to keep this moving along as I know time is short. The process that we're going to be talking about today, the program that we're outlining, is really a process that started back in 2014 when the fire department began to look at ways to reduce readmissions and started to think about the community in a different way as opposed to being more proactive as opposed to reactive with 911 calls. Since that time, the program over those years has evolved to where it is today, a program that has, as we'll share with you, is driving really significant outcome improvements and is a partnership or a collaboration between St. Louis Park Fire Department and Care Resource Connections. In addition, the fire department has other programs tied to post-discharge visits and hospital readmission control, but the one we're going to be talking about today is really the partnership that exists between our two organizations. So when you take a look at the problem that really is driving this, you saw this article in the Star Tribune back in December of 2018, and that was really this increased demand on fire service personnel to do lift assists. And what's happening is fire department personnel are being used at a high rate, growing rate, to do these lift assists in a variety of care settings, private residence as well as nursing home settings. And what that's doing is impacting not only the ability for the firefighters to do the work that they need to be doing in the community, but it's also impacting the reliability. So as those units are tied up on specific types of calls, they may not be available for emergent calls. And that's something that's important to consider when you think about how the fire department should be used. The other thing that's happening that I think is even more important to understand is the compassion fatigue that occurs across the care network as people are continually doing the same things for the patients the same way every day with no results being seen in the way of improvement. So then another story came out on December 11th in the Star Tribune that really I think is probably one of the telling things, the honesties that is going on in our world today, and that is that seniors and St. Louis Park as a senior heavy community really have reached a point where seniors now want to stay in their homes as long as possible. And the reason they need to or want to is because the cost of health care, the affordability, the flexibility of things that they can access through care networks in assisted living or in a nursing home setting are beyond their costs or what they can afford. A lot of assisted livings were actually they stopped putting them up. In other words, there's fewer beds available. So now what's happening is these seniors live silently in their homes, really not reaching out for care other than 911 and putting a great deal of pressure on their family members and the community to support their needs. And that's really not a good quality of life story, and that's kind of what we use as our initial kind of look into the future about what happens next. And that is that this 911 call for this senior is likely a call for help. As we sat down to think about our work, the fire department came up with a 5-year strategic plan in which it identified essentially 3 key components tied to its community health management efforts, and that is improve the community population health, build collaborative partnerships, and ensure sustainability. These 3 key areas are critical as these programs are run across the country in various pilot forms and successes or failures. One of the key areas that's recognizable is that very few programs create a process that's sustainable over the process or beyond the grant funding or beyond the initial pilot. Our mission was to create something that was sustainable so that we could begin to think about how this would look in the future. So what are the issues? And these are not specific to St. Louis Park, and many of you on this call who are listening in are probably experiencing very much these same things. Residents or senior living overutilizing 911. 911 is their primary care provider, and that's creating a huge stress on the overall system. The healthcare system is disconnected and doesn't communicate effectively. Even within the same care team, very little communication occurs. Even though people are connected to an electronic health record, there's very little communication that occurs up and down the care team chain, and that's creating some issues for patients. In many cases, in the patients that we work with, their primary care medical doctor is unaware of the issues their patients are experiencing. They continue to have issues, challenges at home, may or may not share it with family, family doesn't share it with the doc. Or in the case of many of our patients who aren't even transported, the medical team isn't even made aware of their problem because the transport to a facility doesn't occur. Housing contracts that limit health facilities can help. They can be in a facility, but they can't afford the a la carte services, and they go without and rely on 911, and then expensive solutions that are neither affordable or sustainable. These are all common problems in healthcare today, and these aren't ideal or new to the city of St. Louis Park. So a lot of people come to me as the fire chief and say, well, and healthcare professionals ask this question too, so why are firefighters doing this? What's the importance of a firefighter? Well, and I say this with a great deal of pride, but also a great deal of confidence that a firefighter is the most trusted brand in America. People trust firefighters to come into their home and share stuff with firefighters that they don't share with anybody else in their process. They are honest with us. They take our direction. They take our advice, and they trust that whatever we're going to help them through is a good process, a good decision, and because of that trust, they take advantage of the program. For most of these patients, the firefighter that they see at their bedside or as we're picking them up off the floor is probably the firefighter that was there the last time. So it's a face that they've grown accustomed to. The firefighter talks to them using their first name, has the ability to be compassionate, understanding, even somewhat of a parental mode in many cases to try to move this patient down the path. The patients share their social determinants of health with the firefighter. They let them know where those barriers are. If it's financial, if it's my daughter doesn't live close to me anymore, I can't seem to get my medication. All those things are shared with firefighters that they may not share with others who they feel might be motivated to move them into a different care setting. And because of that, they don't share it with them, but they will share it with the firefighter. And then firefighters are results-oriented, and they're moved to provide care. Just like anybody else in the care team, firefighters need to be recognized as an important or integral part to the care team because they are first on scene and the first to work with the patient, and they're as oriented towards providing positive outcome improvements as anybody else in the healthcare system. So the process, the way it works in St. Louis Park, and the way the program that we're going to kind of show you data on today is really designed in three different components. One is the referral process. Now, the referral process is the result of a 911 call. So firefighters on shift are responding to an EMS call. About 75% of our calls are EMS calls. And so they respond, they identify a need. Through their cues and clues that they see on scene or talking with the patient through the social determinants, determine that there is a need. There's a gap in that patient's ability to serve their own healthcare needs. And so they create a referral. They ask the patient for a verbal consent, and that referral process then gets put into an electronic healthcare record that moves through and then becomes part of the care navigation system. Following up on that referral process, within that same day or the following day, the firefighter, EMT, community EMT can then begin to a care navigation process, which is really the firefighter showing up at the home of the resident, saying, hey, the firefighters were out here earlier today. I just wanted to follow up with you and talk to you about some of those things that we might be able to help you with. And so within that 24-hour period, generally, the firefighters are on scene with the patient, talking about the solutions, possible solutions that they could be gaining. That information in care navigation then gets rolled into the patient's electronic patient care record, and then that is forwarded to our care coordinator group, which is really Amy Lucht and Care Resource Connections. Through that process, then the care coordination process, and then the management of the care team and the information within the care team, likely there is going to be some sort of a community MT or healthcare home kind of a visit that really brings that community MT, that person who's been part of the relationship with the patient, back on scene as an EMT You follow up with the patient, just manage or assess their chronic conditions, make sure that they stay connected to the care team, identify gaps, and then through our quality assessment tools, then be able to assess if progress is being made. And Amy will talk a little bit about that on this next slide.
Well, the fire department care navigation and care coordination is patient-centered. The goal is to empower patients to become active participants with their care and their primary care provider and care team. Community-based philosophies contain a fundamental principle that the perspectives of healthcare practitioners and community members must be integrated. This graphic shows how the patient is centered in the middle here, and we have our groups with other circles branching out. So our model illustrates the focus of this philosophical shift, demonstrating our service partners that have organized here in St. Louis Park in collaboration with other healthcare professionals and community resources. With care tied closely to these groups, relevant services can be provided in a timely manner, along with an emphasis on community involvement, prevention, and education. So the home safety check visit is designed to tie into that patient-centered medical home or healthcare home model that focuses on what patients want, a healthcare team that focuses on them and their needs. The firefighter EMT, community EMT, gathers the information, and once that's completed, sends it to care coordination. Care coordination makes the necessary referrals for food and other community resources as needed. Then says that ordering primary care providers a visit note to incorporate into the patient's care plan. So who can get a visit? Effective January 1st, 2017, the Minnesota legislature enacted into law the new provider type called the community emergency medical technician to meet the healthcare needs of these recipients within the first 24 to 48 hours of being discharged from a hospital or a nursing home, or for safe home checks due to multiple calls for assistance for help in their home. So after the visit is completed, we go through this Promis survey. This is what the firefighter does during the visit. And this is a set of patient-centered measures that evaluates and monitors the physical, mental, and social health. It can be used with general populations or with individuals living with chronic conditions. The most impactful data gathered from the survey reinforces what the fire department's witnessed while on a 911 call. Community members living in isolation without social support, unable to manage their chronic health conditions. We follow up with the patients in 30-day intervals, confirming connections to care services.
When you take a look at the outcome improvements that happen as a result of these measures, so this is what happens when you measure the patients over the Promis survey, and you can see over the original intake Promis survey to the time at 90 days, a significant improvement in how the patient not only feels about their health care, but feels about the potential, the resiliency of the patient to move to the next level or to stay out of the 911 system. So this is a significant measure, and this is something that we will continue to do for our patients as they come into the system. So part of the we used to be that firefighters would go on these 911 calls. We would go out and we would see needs, and we would come back to the fire station. We would sit around the table and we talk about somebody's got to do something. I wish somebody could intervene. I wish there was a place we could send that patient, because these are the things that we were seeing. And as a result, firefighters now today have a solution, have a way to create a solution for the patient. But these are the things that the firefighters are identifying, unmet needs on those initial care navigation visits, everything from extensive falls to mental health issues, a need for additional community resources. These are all being measured and tracked. This is since January through March when we really started to move this program into this type of level. This is what we've been measuring just in 90 days.
Let's just talk a little bit about the transport data. St. Louis Park is in the heart of the metro, and with several different healthcare systems engaging with our community's residents. Where patients have chosen not to be transported, the firefighters are trained to identify the needs and ask for open and willingness to connect to the resident with those community resources. It's important to highlight, while this program is utilizing firefighters, EMTs, and community EMTs at the top of their scope, this is more than just the firefighting CEMT program. It's a community population health initiative that the City of St. Louis Park believes that is in the best interest of their residents. A total of 297 care and service connections have been ordered with this program since January 1st. And out of those 297 referrals for care and service, only 2 residents have been readmitted to the hospital. Both of those residents we have sent back to the hospital after speaking with the patient's primary care team for further evaluation. One for an MRI and the other one for an adult with failure to thrive after a VA report was filed. Both residents have consented to share their stories and have provided testimonials on how this program has helped them. Both Betty and Pam were high utilizers of the 911 system. After a program intervention, they're now living beyond their diagnosis. They are thriving and experiencing the impacts these interventions had on their overall quality of life. We've had family members rounding back with the fire department letting us know that this program has impacted them as well, even after Gloria has lost her loved one. And it's important to note that the healthcare workers also rounded back with us on this program and how this has impacted how they're able to engage with their patients.
So as we think about how this program builds and grows and sustains, it really is tied to building collaborative external partnerships. There is no one entity within healthcare that can address all of these needs. There needs to be a group think, if you will, about this. So healthcare system, healthcare payers, these are all people who need to be more engaged, and we need to bring to the table to talk about how this program can be evangelized through this network. Local provider groups, including and not limited to other fire departments who could benefit from this as well. In order to ensure that stability, we need to make sure that we're always focusing on the right way, the right resource, and the right cost. Stop thinking about the traditional way. Stop building on the old methodologies and start thinking about a new way to attack the problem. Build on those existing trusts, that are between the firefighter and the community. Make sure that you're establishing revenue that offsets cost. In government, that's an important model to understand. And then you got to build financial models that are realistic and relevant. Be honest with not only your elected officials, but honest with your stakeholders as to what you believe can be achieved. And the future state then ultimately is to capitalize on the lessons learned. One of the key areas is on the mental health area with our police department, to think about how we can start to use this care navigation and care coordination to serve the needs of the mental health crisis that's happening in America. Build or expand other healthcare systems who might be discharging patients into our community. Providers such as transportation. It remains one of the highest requested gaps is transportation. And start to focus on education for reducing risks and falls, diabetes, etc. in our senior homes and our senior living facilities, which will then obviously reduce or eliminate 911 calls. So if you have any questions or things you'd like to know, we can move through it very quickly, but I want to make sure you know if you need to get a hold of us to know more about this program, here's our contact information. And thank you for listening. Janelle?
Oh, thanks so much, Chief Steve and Amy, for this great information. Our time is almost done, so I hope if you have questions, I think we'll just have you email directly to either Steve, Amy, or Rory. And let me just kind of close up here a little bit. Our webinar is done for the day, and our next webinar for the Success Story series is called Changing the Culture, Improving Recognition and Management of Sepsis. It's Thursday, May 30th from 1 to 2 Eastern or 12 to 1 Central. Before you close out today, a survey will pop up with an evaluation to it. It's also in the chat now that you'll see, and you'll receive an email as well for those that registered. So this was recorded, and it will be available on the Lake Superior Quinn YouTube channel in about 2 weeks. You can just Google Lake Superior Quinn YouTube, and you'll find it under the Coordination of Care channel. So thanks so much, everybody, for participating, and have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.